Welcome back to Anatomiqa. To recap, in the previous session, we discussed about different types of fracture, stages of fracture healing, that is inflammation, formation of soft callus, hard callus, and bone remodeling, and finally, local and systemic factors that affect the bone remodeling or healing. In this session, we will be discussing on development and ossification of long bone. The learning objectives of this session are: explain the prenatal and postnatal development of bone, list the types of ossification, describe the factors that affect ossification, explain the relationship between ossification and radiological images, describe the effect of X-rays on bones. Ossification means the process of bone formation. One should know the difference between ossification and calcification. They are not synonymous. Ossification involves differentiation of osteoblasts, secretion of characteristic organic intercellular substance, including collagen fibers, and calcification. Calcification takes place by depositing calcium crystals along and within collagen fibers. The entire process, including calcification, is called ossification, whereas calcification is just a part of it. Bone formation can happen without calcification in abnormal calcium metabolism, forming uncalcified bone called osteoid. Apart from bone, calcium salts may be deposited in some other tissues like arteries, for example. While calcification in bony tissue is normal, calcified arterial wall is abnormal. Before 8th week of intrauterine life, the human embryonic skeleton is made of fibrous membranes and hyaline cartilage. After 8th week of intrauterine life, bone tissue begins to replace the fibrous membranes and hyaline cartilage. Before going into the details of bone development, let us look at the formation of cartilage. Cartilages are derived from mesenchymal tissue. The following are the stages of formation. Mesenchymal cells become closely packed to form the mesenchymal condensation in the region of cartilage formation. Mesenchymal cells differentiate into chondroblasts. Chondroblasts deposit intercellular matrix and differentiate to form chondrocytes. Mesenchymal cells surrounding the cartilage form perichondrium. Depending on the type of fibers and amount of fibers in the matrix, the following cartilages are formed. Hyaline cartilage with fine collagen fibers in the matrix, elastic cartilage with abundant elastic fibers in the matrix, fibrocartilage with dense collagen fiber bundles in the matrix. Now coming to the formation of bone. Bones are mesodermal derivatives, except in the facial bones, which is formed by neural crest contribution. As discussed earlier, the process of formation of bone is called ossification. Ossification in bones are of two types. Membranous ossification, that involves the direct conversion of mesenchymal tissue to bone. Endochondral or cartilaginous ossification, that involves the conversion of mesenchyme to a cartilage which is later replaced by bone. Now let us see the details of membranous or intramembranous ossification. As discussed in the previous slide, in intramembranous ossification, the mesenchymal tissue directly forms bone. This method occurs in bones forming the skull cap. The stages of membranous ossification includes 6 stages. The first stage is the mesenchymal condensation. Star-shaped mesenchymal cells condense and differentiate to spindle-shaped fibroblasts that form a fibrous membrane. The second stage is the osteoid formation. Fibroblasts differentiate into osteoblasts. These osteoblasts lay down the early bone matrix, that is the organic intercellular substance, and forms uncalcified bone called osteoid. The site where the osteoblasts first appear is known as the center of ossification. From the center of ossification, the osteoblasts proliferate and differentiate in radiating manner. The osteoblasts cover all the sides of the osteoid. As new bone is added, one end of the osteoid increase the length and help to spread the center of ossification. This end forms the free end and develops into bony spicule. The other side of the osteoid produces lamellae. As more and more matrix is deposited, some osteoblasts get entrapped in the lacuna. There will be many osteoids developing from different ossification centers. The third stage is the calcification of osteoid. Osteoblasts, in addition to organic matrix, deposit calcium salts in intercellular matrix. As the osteoid is forming, on one side of the osteoid, the calcium will be deposited and is converted into bone matrix. The osteoid, which is elongating and expanding by the lamellae, is converted into calcified bony spicules. The fourth stage is the formation of woven bone as the matrix is getting calcified. The trapped osteoblasts in the matrix get differentiated into osteocytes. The osteoids forming spicules fuse with each other to form plates of trabeculae. Arrangement of collagen bundles running in different directions produces woven or cancellous or spongy bone. The mesenchymal tissue between the trabeculae of spongy bone gets vascularized and differentiates into bone marrow. The fifth stage is the formation of compact bone. Continued deposition of lamellae on the trabeculae reduces the spaces around the blood vessels, which is gradually converted to the Haversian canal. These changes converts the woven bone into compact bone. The sixth stage is the stage of bone modeling and remodeling. Fusion of progressively growing bone or immature bone give a primitive shape to a bone model forming lamellar or mature bone. This is a diagrammatic representation for the understanding of the process of how the modeling of bone occurs in a skull. Continuous deposition of bone by osteoblasts on one side, forming a new bone, and reabsorption or resorption of the extra bone formation by osteoclasts on the other side give the definite shape to bone, forming the inner and outer tables of skull bone. The connective tissue surrounding the developing bone, which does not undergo ossification, forms the periosteum and endosteum. The vault of the skull in the postnatal life enlarges in appositional method. New bones are added to the convex surface of bones by osteoblasts, and simultaneously inner surface of the bones is resorbed by the osteoclastic cells. As the cranium enlarges, the curvature of bone decreases. Bones formed by the membranous ossification are called membranous bones. The bones which develop from intramembranous ossification are frontal, parietal, temporal, occipital, part of mandible, most part of the clavicle, and the scapula. With this, the intramembranous ossification is completed. Now, let us see how the cartilaginous or endochondral ossification occurs. Most bones of the body ossify in cartilage. This method is described in stages with reference to a simple long bone. As already told, it involves conversion of mesenchymal tissue into cartilage that later is replaced by bone. The bones developed by cartilaginous ossification are called cartilaginous bones. The examples of bones developing from endochondral ossification are long bones except clavicle, base of the skull, vertebrae and ribs. Stages of endochondral ossification. This is the development occurring prenatally, that is in the womb of the mother, which we call it as intrauterine life. We will discuss the stages one by one. Mesenchymal condensation. Mesenchymal cells of the limb bud form condensed mesenchymal tissue at the site of bone formation. Formation of cartilaginous model. At the site of mesenchymal condensation, chondroblasts appear and deposit hyaline cartilage. The cartilage model grows in length by interstitial method and in width by appositional method. Interstitial method takes place in the substance of the cartilage and the growth occurs nearer to its ends. Appositional method takes place at the periphery where the cells are added at the surface. The cartilage cells are arranged in rows of longitudinal columns and are named from the end to the midsection of the model as follows. Zone of proliferation by mitosis, zone of maturation of the cartilage cells, zone of hypertrophy of the cells, zone of calcification of the cartilage cells. Let us see brief details of each stage one by one. In the zone of proliferation by mitosis, the cartilage cells proliferate and increase in number. In the zone of maturation of the cartilage cells, the chondroblasts differentiate itself into mature chondrocytes. Stage of cartilage hypertrophy. At the site of bone formation, in the center of the shaft, the cells of cartilage, now which is chondrocytes, increase in size. Stage of calcification. These hypertrophied chondrocytes now start secretion of alkaline phosphatase and deposit more and more calcium in the intercellular matrix. Soon, chondrocytes lose nutritional source and die due to calcified matrix. The death of enlarged chondrocytes produce large spaces now called as primary areolae in the midsection of the model. Stage of formation of periosteal buds. As these changes occur simultaneously, the perichondrium develops osteogenic potential. Perichondrium is vascularized and the chondrogenic cells become osteoprogenitor cells. Osteoprogenitor cells differentiate into osteoblasts. Osteoblasts lay down a thin layer of bone underneath the periosteum on the surface of the shaft by appositional method and form periosteal bone collar. This compensates for the weakness of the model. The perichondrium is now called the periosteum. As this is occurring simultaneously, perichondral vessels and osteogenic cells invade calcified matrix to form periosteal bud. Stage of formation of secondary areolae. Periosteal bud excavates through the bone collar and osteoclasts in the bud removes calcified matrix from the wall of primary areolae and forms large cavities called secondary areolae. The spaces gets filled with primitive bone marrow underlined by osteoblasts. The perforation of bud persists as the nutrient canal. Formation of osteoid. Osteogenic cells, that is osteoblasts, proliferate and deposit new bone, forming a gelatinous matrix along the wall of the secondary areolae, which is nothing but calcified cartilage matrix. This newly formed mass is called osteoid. Now, let us take a part of the wall of secondary areolae with the osteoblasts and osteoid and see how the lamellae is developed. Stage of formation of bone lamella and trabecular bone. Intercellular gelatinous matrix of osteoid deposited by osteoblasts get calcified to develop the first lamella of spongy bone. Now osteoblasts lay another layer of lamella over the surface of first one to form second lamella. Then the osteoblasts lays another layer on the surface of second lamella to form the third lamella, and the process goes on. Lamella 1 becomes superficial layer now. Osteoblasts trapped in lamellae form osteocytes. The multilamellar portion is now called trabecular bone. Later, the calcified cartilage matrix in the core of trabeculae is removed by osteoclasts, giving rise to mature trabeculae of spongy bone. The central part of the cartilage model where these changes occur is now called the primary center of ossification. Similar process occurs along the developing shaft, resulting in the formation of diaphysis of the bone. That is, the ossification extends in longitudinal direction by the successive processes of proliferation, maturation, hypertrophy, calcification, and death of cartilage cells due to calcification followed by ossification. Medullary cavity is formed and simultaneously new bones are deposited beneath the periosteum by appositional method. Until now, we discussed about the prenatal development of bone. Now, let us see the postnatal development of bone. Around birth, most long bones have a bony diaphysis surrounding remnants of spongy bone along with active sites metaphysis, two epiphyseal plates or cartilages, a widening medullary cavity, and two cartilaginous models of epiphysis. Before birth, the epiphysis remains as cartilage and it starts developing as bone after birth. After birth, capillaries and osteoblasts will migrate into the epiphysis and create new centers of ossification called secondary ossification center at the ends of long bones forming the epiphysis. The cartilage of the epiphysis undergoes the same sequence of events as in the diaphysis. But unlike diaphysis where it spreads in one direction, in the secondary center, the cartilage growth and subsequent ossification spreads out in all directions. Entire cartilage is replaced by bone except in two regions. At the free end, which remains as articular cartilage throughout life, which regulates growth of epiphysis, and a small cartilaginous epiphyseal plate at the juncture between the epiphysis and the diaphysis, which persists as long as the bone grows in length. The epiphysis will be transformed into spongy bone. Epiphyseal cartilage regulates longitudinal growth of diaphysis. When growth is complete, the epiphyseal cartilage is completely replaced by bones. This is when the bone ceases to develop and we call it as ossification is completed. Now let us see the methods of bone growth in length and width after birth during postnatal life in young growing long bones. Growth of long bone in diaphysis. We will first see the increase in thickness and formation of marrow cavity. Periosteal collar increases in the thickness by deposition of more layers on outer surface of bone by osteoblasts through appositional method. This makes the bone thicker. Simultaneously, osteoclasts remove lamellae from the inner surface of bone, leaving behind a bone marrow cavity. This results in an increase in the shaft diameter even though the actual amount of bone in the shaft is relatively unchanged. Under growth of long bone, let us see how increase in length of diaphysis occurs. The length of bone increases by lengthening of epiphyseal cartilage and its simultaneous conversion into new bone at metaphysis. Length of diaphysis increases by interstitial growth of cells of the epiphyseal cartilage, thickens the cartilage followed by deposition of bones at the metaphyseal end of diaphysis through calcification, death and replacement of the cartilage. The deposition of bone process at its diaphyseal surface reduce the thickness of epiphyseal cartilage. So both these processes helps epiphyseal cartilage to maintain the same thickness throughout the bone growth until it completes its ossification. Epiphyseal cartilage and metaphysis constitute together the growing zone of a long bone. In the developing bone, epiphyseal cartilage shows the following structure from epiphysis to diaphysis. Zone of resting cartilage, zone of proliferation in which young cartilage cells are arranged in rows of longitudinal columns, zone of mature cartilage where cells start secreting the alkaline phosphatase and deposit calcium, zone of calcified cartilage where the cells die in calcified matrix, zone of ossification is the active site of bone formation which is the metaphysis, the terminal portion of diaphysis. On completion of bone growth, epiphyseal cartilage stops proliferation and epiphysis fuses with diaphysis. So in simple words, epiphyseal cartilage which is close to the epiphysis of the epiphyseal plate divides to create more cartilage, while the diaphyseal cartilage which is close to the diaphysis of the epiphyseal plate is transformed into bone. This increases the length of the shaft. The differences in the processes in epiphysis and diaphysis are: in epiphysis, the stages are occurring in articular cartilage, and in diaphysis, the stages are occurring in the epiphyseal cartilage. The increase in length and thickness occurs in all planes and directions in epiphysis, but in diaphysis, the length increases in one plane and thickness in one plane. At puberty, growth in bone length is increased dramatically by the combined activities of growth hormone, thyroid hormone, and the sex hormones. As a result, osteoblasts begin producing bone faster than the rate of epiphyseal cartilage expansion. Thus, the bone grows while the epiphyseal plate gets narrower and narrower and ultimately disappears. A remnant of epiphyseal plate will be visible in the form of epiphyseal line on X-rays. Ossification in short bones. Short bones increase in size by the interstitial growth of articular cartilage, similar to that of epiphysis. As we were discussing the ossification, you would have noticed few highlighting features. These features are grouped as laws of ossification. For every law of ossification, there are exceptions which we will be going through. We have noticed during the discussion that ossification starts before birth and appear as a small dot. The starting site of bone formation is called center of ossification. The first law is center which appears before birth at 8 weeks of intrauterine life is called primary center, which develops into diaphysis. Usually, one primary center appears in the middle of the bone, but in clavicle, there will be two primary centers, which is an exception to this law. The second law is center appearing after birth is called secondary center, which develops into epiphysis. But in the lower end of femur and upper end of tibia, the secondary centers appear before birth, an exception to the law. The third law is multiple secondary centers can appear at each end. The multiple secondary centers fuse first with one another and then fuse with the rest of the bone. But in medial epicondyle of humerus, the multiple secondary centers directly fuse with the diaphysis separately, which is an exception to the law. The fourth law is the secondary centers at both ends do not develop simultaneously. Secondary ossification center will first appear at one end and then at the opposite end. The secondary ossification center, which appears first, fuses last with the diaphysis, and the epiphysis, which develops later, fuses first with diaphysis. But in fibula, the secondary center, which appears first, fuses first with diaphysis, an exception to the law. The epiphysis, which fuses last, is called the growing end of the long bone. The nutrient canal is directed away from the growing end and can be remembered by the dictum towards the elbow I flow, from the knee I flee. You can download this table by clicking the link in description box. Let us look at the effect of X-rays on bones. X-rays penetrate bones and create images of the internal structure of bones on film or a digital detector. X-rays interact with minerals in bones, particularly calcium, and create a visible shadow of the bones on the film or detector. This makes X-rays a useful diagnostic tool for detecting fractures, tumors, and approximate age in bones. However, repeated exposure to X-rays can increase a person's risk of developing cancer, so they should only be used when medically necessary and the benefits outweigh the risks. These are the X-rays of the knee joint showing the ossification centers of different individuals at different ages. To know the age, appearance of ossification centers of each epiphysis is of importance to estimate the approximate age of individual. In the X-ray A, The secondary centers have appeared for the lower end of femur and upper end of tibia. The secondary center is not yet developed for fibula. Between the shaft and the secondary center is the epiphyseal cartilage or plate. Since the ossification center for fibula is not yet appeared, the X-ray is of the child who is around or below 3 years of age. In the X-ray B, the secondary centers have expanded to form the epiphysis and the secondary center for the fibula has appeared. The epiphyseal plates are clearly visible. In the X-ray C, the epiphysis is well developed and the narrowing down epiphyseal plates are visible. X-rays B and C is of the teenager or of the adult below 21 years of age since the ossification is not completed. In the X-ray D, ossification is completed by the fusion of epiphysis and diaphysis. If epiphyseal plates are not visible, the X-ray is of the adult since the ossification is completed. Now, let us see the factors affecting growth of bones. The factors regulating bone growth may be nutritional, hormonal, genetical, and mechanical. Nutritional, vitamin A controls the activity, distribution, and coordination of the osteoblasts and osteoclasts. Deficiency of vitamin A causes a disturbance between the bone formation and resorption, the latter being slowed down. This reduces the size of the spinal and cranial foramina with eventual compression of the nerve roots. High vitamin A concentration leads to rarefaction and resorption of bone. Deficiency of vitamin C interferes with the production of organic intercellular matrix, calcification being normal. This causes deficient production of the trabeculae on the epiphyseal side of epiphyseal cartilage and separation of the epiphyseal plate may take place. Deficiency of vitamin D is essential for the absorption of calcium and phosphorus from the intestine and maintains their concentration in the blood plasma. In deficiency of vitamin D, calcification of the osteoid matrix is interfered. In rickets of children, due to less calcification, the cartilage cells of epiphyseal plate do not die and the plate becomes thick and irregular due to weight bearing. Rachitic children may be bow-legged. Osteoid tissue may be deposited under the periosteum of metaphysis, forming metaphyseal region knobby. In osteomalacia of adults, maintenance growth, that is old aversion system replaced by new one, is affected by imperfect calcification. Hormonal factors. Hypersecretion of alpha cells before puberty causes persistent growth at the epiphyseal cartilages with consequent gigantism. Hypersecretion after puberty causes renewed subperiosteal deposition of bones in various parts of the body, notably in the hands, feet, and skull. This is known as acromegaly, which is a reversion of gorilla type. Hypopituitarism of infant causes failure of the normal growth of bones with consequent dwarfism. Parathyroid hormone and calcitonin of parafollicular cells of the thyroid gland by their specific action on bones are essential for maintaining and regulating the calcium ion concentration of the blood plasma. In hypersecretion of parathyroid hormone, the calcium is removed from the bones by stimulating osteoclastic resorption. This causes rarefaction of bone known as the osteoitis fibrosa. Castration during the growth period leads to delay in the union of epiphysis. This accounts for the disproportionately elongated limbs, which are often characteristics of the eunuchs. Genetical factors. Chondrodystrophia fetalis. Here, the endochondral ossification fails to occur properly. The cartilage bones are affected whereas the membrane bones develop normally. This condition is due to autosomal dominant inheritance. Mechanical factors. Bone development depends on stress and strain of bones. It is worthwhile to mention that tensile force helps in bone formation whereas compressive force favors bone resorption. With this, we complete the development of bone. To summarize the development of bone, we discussed types of ossification, various stages of membranous and endochondral ossification, loss of ossification, effect of X-rays on bone, and factors affecting bone growth. In the next session, I will be discussing on clinical anatomy of bone.